Can I? I don't know whether our system has collapsed or bent. I don't know what has happened. But then we are back. Apologies for the cut. Yeah. Can I put back the presentation so we can continue? We just lost the Wi-Fi. So actually the electricity has just gone. So we are trying to come back again now. Okay. Minute, then we are going. So I was saying, I think now we are fine. We will be able to continue again. I was saying that so this is what they found, and to me, it shows that really pressure ulcers are real in palliative care, and we need to put all efforts to manage and prevent them. But then what they found is that most of the things that normally put patients at high risk of developing pressure ulcers is the issue of skin failure, especially with organ failures, and it also may be part of an inevitable part of the dying phase. So sometimes when patients are approaching the end, you will see them developing pressure ulcers because their skin now is getting loose. So this is one of the things they found. So which shows that indeed we need to be cautious of pressure ulcers in palliative care and manage them very well. And then another one that was done was to look at the bedding of pressure ulcers. So they were looking at the bedding . Can you hear me now? I'm having some technical issues here. Okay. So I think now we can continue. I hope you can hear me now. So I was saying this is another study that was also done. And okay, thank you. Then now you can see we are facing some electricity issues here. I don't know what is electricity doing, but it's playing as a bad game. So this one was also done, and they were checking the bedding and outcomes of pressure ulcers in patients with cancer who were receiving another model of home-based palliative care in India. So in their findings, they found that 21 of 108 patients, was 19% patients who have enrolled into this study had pressure ulcers at the start of the home care services. And none of the patients developed new pressure ulcers during the course of the home care. And then complete healing of pressure ulcers was seen in 9 out of these patients, which was 42%. And then the median duration of healing was found to be 56 days. And then the amount of money was equivalent to $1.2 on a daily basis. So what I found in this abstract is the issue of really it's expensive to manage a pressure ulcer. And it's expensive in terms of cost, financially and emotionally. Look at the duration it takes, 56 days to completely heal a pressure ulcer. Another thing I found I take from this one is that pressure ulcers with the proper management, they can be healed, or they can heal other than maybe cancer-related conditions. And look at if it's a cancer patient, then now they have pressure ulcers, they have double pain. So then one of the models that they said then is that home care services delivery are effective in prevention and management of pressure ulcers. So when you have allowed patients to be at home and then you provide them home visit, you find that then you do relieve pressure ulcers. And the issue that shows that then if you put proper management at home, then the patients are able to recover and cope well with the problems that comes with pressure ulcers. So then looking at the risk factors, we know them, but the common ones in palliative care, at hospice we have a lot of patients with stroke, and then some with a more prevalence of pressure ulcers for those who then end up ECOPO or bedridden at the end of the stage of the disease. When they are approaching the end of life, then you find them with mild, moderate pressure ulcers. And then we have those with neurological conditions and those who have spinal dislocations and stuff. You'll find that they also experience sometimes severe and long term. And then you find that relatives, they stay for a long time not presenting the patient to hospital immediately that the patient is bedridden or is wheelchair bound. And sometimes they lack the knowledge to know that being wheelchair bound may predispose you to develop pressure ulcers. So thus it is the common issues in palliative care. You find that leads to pressure ulcers are limited mobility. Sometimes they have weakened immune systems. You know that when they are taking chemo and stuff, sometimes you find that they become weak. And some, because of the illness, they are weak. And sometimes the prolonged period spent on bed and sitting in chairs, also that one. So when you talk of limited mobility, you find that patients end up not walking or exercising. One of the reasons, except the other reasons we have been mentioning now and then, that we need to encourage people to mobilize to avoid the loss of weight and stuff. Encouraging mobility also promotes circulation and prevent pressure ulcers. But then the causes that contribute to pressure ulcers, there are many that we know, the general ones, prolonged pressure, whether bedridden or wheelchair bound. And then another issue is poor nutrition, which comes with malnutrition and dehydration. What we have seen as hospice in our practices, you find that these patients, they end up malnourished because maybe now there is no source of income or there is no source of food that they can get. Maybe the person was able to do or get food for himself or herself, but now because he or she is sick or has been suspended from work, I've got another patient that told me that now he cannot even feed his family because all the funds or the income he gets He has to go for hospital. In our current situation, they even has to buy medication, whether it's theater related or whatever. They have to pay for themselves, even if it's in a government setup, because of sometimes shortage of medications. So you find that then now they have to prioritize their life, and then find that malnutrition takes over the patient and the relative and the family they have. And then sometimes they suffer dehydration, as we have taken it in previous presentations, which is one of the common things that happen with these patients. And then you find that then with the assumption that poor nutrition will lead to pressure ulcers, we find ourselves deciding to go for artificial feeding, and then thinking it will hit the pressure source for these palliative care patients, but only to find that sometimes artificial feeding at some point leads to pressure ulcers itself. It makes the patient worse. And another issue that we have found is skin moisture and incontinence results to a lot of pressure ulcers. In the country, we are grateful that now we can access adult diapers and linen savers from our national medical stores, which is a great achievement, because we were seeing most clients not affording to go buy them from enterprises in the country to buy those linen savers and diapers. But if they are now accessible from government, the patients are now able to get them, and they are able to prevent skin damage related to skin moisture, and sometimes especially incontinence, because that one also leads a lot to a lot of pressure ulcers. There's a patient that we have had who had this experience of getting pressure ulcers related to one, poor prognosis of the condition, being old age, and was bedridden, and then skin moisture and incontinence led to a lot of deep pressure sores on the thoracic scapulas, almost all the back where the pressure points, and even the hips, the buttocks, they were deep pressure ulcers, and they were aggravated by also parenteral nutrition, and also poor prognosis, skin breakdown and old age. Also, we have friction and shear forces. You find that patients, then the way we maneuver them on the bed, you find that the caregivers are not aware of how to move a patient from the bed to the wheelchair, or when they want to make the bed, you will find them moving the patient or dragging them inappropriately. And then the patient will end up developing pressure sores because their skin is fragile. So also skin fragile, when you become old, you are a child, your skin is so fragile. So with these patients, especially those with diabetes mellitus, old age, dementia, stroke, you find out that they last long and they are adults. So you end up finding that their skin becomes fragile and they easily break. And then having chronic medical conditions like diabetes mellitus, spinal injuries that I've mentioned, also predispose or contribute to pressure ulcers, let alone then decreased mobility does that. So these are the things that we see daily with our patients, but sometimes we ignore to educate the patient on what to do. And then how to prevent pressure ulcers, because if it's treatable, we can also try all means to prevent. Actually, looking at that in India, the study said that daily to manage a pressure sore will cost $1.2 US. You can convert it with our rating of 19 Malanga per dollar today. How much does it cost to manage pressure sore daily, and then have it for 56 or 2 months daily? It's expensive. for the patients and for the healthcare system and to us as the care workers too. So we can prevent it. But then we need to understand that, you know, management or palliative care is not a one-man show. It's not about one person or about that palliative care unit nurse or doctor alone. It requires a multidisciplinary approach or a comprehensive approach, especially to address the unique needs of each client, because each client is different. No client will, even if they can have the same, they can all have pressure ulcers, but they have different needs that requires a comprehensive approach when they're approaching them. There's this term we call woundedness in palliative care that requires a lot of care, because we can see the pressure sore that is outside, but there's another pressure sore that is given birth to by the outside pressure sore. So it is essential then to be proactive in managing or preventing pressure ulcers. You know, we need to be very proactive in doing this, because, you know, being reactive to pressure ulcers is very expensive and costly to you as a healthcare worker. Count the minutes you can spend dressing a pressure ulcer that comes with an odor to the patient, to everyone. It becomes very expensive. So then we need to embark on proactive measures to prevent it, because being reactive is very expensive. So one of the things we need to encourage is regular repositioning. You know, even if we are preventing pressure ulcers, I'm just thinking of a patient with pain who feel comfortable when he's sleeping in one certain position. Sometimes we need to understand that you will find that the repositioning issue becomes a challenge to other patients, and we need to find alternative ways to prevent the ulcer. So repositioning. And there's one thing that we normally say, we say 2 to 4 hour change position. Sometimes, on a reality, the caregiver cannot be alone to wake up at night and do it. So we need to find ways to say that how can then we ensure that even the caregiver is not pushed to difficulty in initiating and maintaining sleep, because he has to change the positions every 2 hours. But to prevent the pressure ulcers, we need to change the patient. And we need to discuss with the patient and the caregiver and find a common ground on how best we can do it regularly. You find that most of the patients are bedridden, and you find that nobody is taking care of them. Some of the patients, when you meet them with the pressure ulcers, you will find that nobody was tending them. And maybe the caregiver started to tend them, but then they end up getting tired of tending this person because of body size and stuff. So that's why then we need a comprehensive approach, because we need to help this caregiver deal with burnout, because caregiving burnout for the caregivers is rife, and they end up deserting or neglecting the patient. So another thing we need to also deal with is the skin care. You know, need to encourage our caregivers. Skin care starts from bathing the patient, you know, checking the patient if he's not moist, dealing with sweat, dealing with incontinence, bathing the patient with soap and water, and then applying any lotion, especially I encourage just blue sleep or Vaseline to help the skin moist. When we are talking of skin care, we cannot deal with skin care without dealing with nutrition. We talk about balanced diet, we talk about giving the patients diet food. And when we talk about feeding the patient, we are to be comply with the ethics, because sometimes patients will say now they don't want to eat, and not because of anorexia, but the vector's nerve is no longer detecting any hunger, especially for patients who are approaching end of life. You find that now even feeding becomes lethal to them, so we need to be cautious of that, but we need to feed them. So that's the reason when we are proactive in our preventive measures, we need to assess our patients, what are they eating and how frequent are they eating? And once we ask them what are they eating, we need to go deeper to the issues of affordability. What food do they afford and how best we can do that? Then we need the dietitians there, we need the social workers there to help us mobilize resources and support them. For that reason, you'll find that even in hospice, we try to mobilize them. Currently, they are even getting spinach. You'll find them getting lettuce from us. Sometimes through the support and donations of other stakeholders, they get rice. Sometimes they get proteins in forms of eggs and stuff, because we understand that diet is very critical for these patients. And then another issue is the use of supportive surfaces, especially pressure relieving mattresses and cushions. When you go to the homes for us, I don't know for those who are in the hospital, I hope the beds in hospital, they are comfortable. But then you find that they don't get pressure ulcers in hospital most of the cases, they get them from home. In my practice and experience, I've found that most of the patients you find them bed sores. You will find that the bed is not comfortable or is not soft. Some are sleeping actually on mats, so they're just sleeping on the floor. There's nothing. And worse, the blanket has a lot of debris, so the skin has a lot of creases. The bed linen has a lot of creases, and then looking at the patient's skin, and then you find that they are not well cushioned. Yet cushions, we can just make them even at home. So we need to teach them how to make soft cushions using available resources at home. So then they can use them to support themselves. And then the last but not least, proactive steps that we can use is to provide education and training. You know, this one, we can take it lightly, but education, you know, to the smallest level of information, how to tell a patient, how to bath the patient, how to feed and when to feed. You know, educating them on those issues. That's why we need this dietitian. At some point, we had a patient who was a nutritionist who volunteered to be here for some time, and she used to help teach the patient and family members how to cook food to be nutritional. You know, cooking spinach until it is brown, you know, it can't work like that way. So with educating them how to do it, so it's very informative and empowering them to understand the disease trajectory the patient is going through and preparing for the worst and hoping for the good. So that they can be proactive for themselves. You know, you find that caregivers when their relative is gone, you find them developing depression, you find them developing burnout, you find them developing anger issues and unresolved grief, and then you find them suffering physical problems, back pain, and a lot of issues because there was no proper education and training on caregiving. So for that reason, also as hospice provide such training and education to empower them to do better at a group level and at an individual level in our home visits. And then we also look at pressure ulcer management in general. And we need to understand that whenever we are managing pressure ulcers, we need to have the proper goals, and these goals must be discussed with the family, caregiver, and the patient. There is nothing so painful to do all you can and give patients medications and supplies for wound care, only to discover that they don't understand why and what is the goal. Then they tend to go for other alternatives and neglect what you were giving them because they didn't have the same goal as you are. So you know, finding patients taking all sorts of medications and advice is shared with them because they don't have the same goal as you, a clinician. So it's very important that we have the same goal. You know, it's better to have time with the patient, discuss what we are going to do than rushing to do what we want to do. So we improve the quality of life of the patient and improve the health of the wound. So we want to see the wound healing because it's a pressure ulcer. And remember, for a wound to heal, there are multiple factors that must be there. Sometimes, let me make an example. My patient has a pressure ulcer and a complicated diabetes mellitus that has a challenge. So you find that maybe the wound will heal, but my patient cannot leave the bed at point in time. My patient has diabetes mellitus. So for the wound to heal, the environment for it to thrive actually is very difficult to do that. Sometimes we find that the resources that we have are not available to help the wound heal. And we call those wounds a maintenance wound. So if the wound will be healed, if all healing factors were available or conducive, but because not all the healing factors are available, then now we are maintaining this wound. That type of wound, we also have it in palliative care. So, but then the major goal that we have whenever we are managing pressure ulcers is to improve the quality of life of the patient. There is nothing so painful to sleep, eat 24/7 with a pressure ulcer. So there's nothing so painful like that one. So we are trying by all means then to help our patients that, you know what, we need to heal or improve the quality of life. So we are doing that every time we are managing pressure ulcers. So then, what do we do when we are doing that? The first and very important thing to do is to do wound assessment. It's very important that as possible as we can, we do wound assessment. We look at the size, how big is the wound, the depth, how deep it is, because even the depth will tell us the stage of the pressure ulcer. And then we stage the wound. At what stage we look at the wound base, how is the wound base, any ischar or any oxidate, and what color of the oxidate, and how is the liquidity of the wound discharge, you know. We look at the undermining. When you access the wound, you look at the undermining of the skin. Is my wound small but dipping horizontally? We look at the peri-wound, the top part of the wound. How is the peri-wound looking like? So we look around the peri-wound. That one will tell you if it is widening on top. And then if it's widening on top, definitely the wound is discharging, and these enzymes from the wound are degrading or digesting the peri-wound on top. So if my peri-wound is engorged or is facing inside, those are signs that the wound is so dry, so the skin on top is going down inside. So yeah, if my wound is inflamed, the peri-wound is inflamed, then it tells me that there's edema, the wound is edematous. So, you know, you assess the wound, and then you look for signs of infection, as I mentioned, that the peri-wound, the color of the wound. You know, it's very important to know the color and educate the patient. If my wound, then I've been dressing the wound, but now it's moving from brownish or greeny color-like or yellow towards beefy, reddish color. You know, that one is a promising wound. So then now I need to go to the other area of saying I need to prevent trauma as possible as I can, and change maybe the dressing tactics. So then also what we need to do once we've done our assessment is to promote and encourage wound cleaning. Wound cleaning helps prevent infection and promote healing. But when we are doing the cleaning, it's very crucial that we educate our caregivers, because most of the time the patients are not with us in the hospital, they're at home, that they prevent trauma. There's what we call umtelemba. You find people pushing all stuff there. We have had a project on wound management. People were saying strange things that they used to manage wounds. So we need to encourage them not to traumatize the wound base, especially that the wound will be forced into bleeding now and then. Yeah. So we promote and prevent that one, cleaning it. And then we do the dressings. Not all dressings applies in all wounds. We need to understand that there are dressings for dry wounds, there are dressings for wet wounds. So we need to apply the correct wounds. There are dressings for non-infected wounds and dressings for infected wounds. There are dressings for healing and non-healing wounds. For these ones, dressings, we need to be very cautious when you're dressing pressure ulcers. You cannot apply your peroxides here. We need to use proper dressings. So when you are using dressings, your proper dressing, how will I judge that this dressing I'm using is going to be proper for my wound? One, when you are dressing your wound, your dressing should maintain a moist environment to promote healing. My dressing must not leave the wound in a pool. You know, we used to leave betadine inside there. Don't leave your wound in a pool of your dressing or fluid. Don't make it wet, but don't make it dry. Keep it moist like a skin, not dry, not wet. Then if your dressing will keep your wound like that one, it's a proper dressing. Another one is to protect the wound from infection without making your wound wet, without making wet, but making it or protecting it from infection. Normally we have silver pigmented gauzy dressings. We have antibiotic, okay, we have silver sulfur diazide, that is proper for wound dressing, many more antibiotics that can accept betadine. Accept betadine. Betadine is not good to dress healable wounds. It is good for non-healable wounds. Yeah, not for these ones. So that for that reason, we have, instead of using it for smell, we better use Flagyl crush tablet or Flagyl liquid. And whenever we are going to use the Flagyl is so painful to a wound, then we need to coat it with analgesics. If you can have lignocaine or a liquid dose of morphine and mix the tablet with and then press the wound to prevent pain. So yeah, so you need to protect the wound from infection. So then your dressing is working very well for that wound. And then it manages excess exudates, especially for those draining wounds. It has to manage it, and then you will have your silver pigmented dressings, like we have our Actisol and others. So then you will be managing dressings. And if you are managing excess oxybate, you need to ensure that even if you have put these foams, because we call them foams, you need to check that whenever they have drained, then they don't then corrode the peri-wound, because there are these protein enzymes in the wound that digest the peri-wound. So then you'll find your wound on top opening very wide because the oxidate is now corroding on top. So we need to manage the excess wound. So if you are choosing your dressing, it must be to maintain a moist environment, not dry nor wet. It has to protect the wound from infection. So we can't leave the wound on open. I have to close it. And then maybe I will need bandages, I need gauze, I need strappings, you see. And then you have to manage excess exudate so that that. And then sometimes you find that when you talk of infection, there's an scar. that hard, dark layer on the wound base, which is not good to be there, because then it prevents air circulation, it prevents oxygen supply through blood circulation. So with Ganzi, for a wound to heal very well, there should be those factors in place. So we have to eliminate the two, and then we go for advanced management like debridement and stuff, but we'll share that one very soon. And then there are dressing types that I've mentioned. We have hydrocolloids for debridement. I would mention that way. They help us when you want to debride slowly the wound, especially when there are scars. They help very well, the hydrocolloids. Then we have the forms, forms we have, I've mentioned, like silver pregnated dressings. And then we have the alignants. Alignants, they help in oxidate, excess oxidate wounds, because they also help when the wound is so deep, because then you put it, it's like a coating, like then it exchange the salts and the wound, and then you find that it's able to drain and heal the it has the antibiotic effect, but it's very expensive. Calcium alignants, so they are very expensive, but we can get them if patients have money. And then another crucial part of pressure ulcer management is pain management. Like we have shared it before, it's very important that we don't stress patients on pain. We manage pre and post dressing, we manage pain. So it's one very important that whenever we are dressing or managing pressure ulcers, we encourage even caregivers to manage and assess for dressings. Sometimes some patients cannot even speak, so we need to understand that dressing is very painful unless the patient has no sensitivity to that area. But then when we're talking also about pain management, we cannot exclude managing psychosocial pain, spiritual pain that comes with the wound itself on the patient, which means include the smell, which includes the dignity, the self-esteem, you know, the social neglect, all those pains, we then need to also manage them. So for that reason, we also have what we call multidisciplinary approach. We have wound specialists, sometimes they are private practicing and they require a lot of money, but then if patient does have money, you can engage them, they can help. But then we also need to talk about nutritional support as it is with prevention, because then for the wound to heal, we need to increase the amount of proteins and vitamins and minerals the patient is getting, especially proteins that helps in body building. So we have to help our patient eat more proteins because they help in body building. Actually, there is no medication from this management. We can agree today that there is no medication or drug that can heal a wound. But the healing of a wound is a natural process. The all things we do on the wound is to help the body strive and be able to use the available resources, which is the oxygen, which is the glucose and protein that is running through the blood, you know, the air that is circulating to build itself back to its normal state. So we are using the dressing, so we eradicate all these problems, infections, excess exudate, and all stuff, so that the body can heal, to promote healing. So we need to maintain a good environment, then the body will heal itself. For the body to heal, it requires an immune system that is stronger, it requires a diet that is proper, including has protein. And then we can look maybe closer to the stages of the wound that we know. I know we understand and know these stages. So when we talk of the stages, we have stage 1 to 4, and 1 being the early stages that notifies us that danger is coming, and then the last stage being the worst. So when we talk of stage 1, we know that here the skin is just ready for those who have a white color, and is looking a little bit darker green for those who have dark skin. And sometimes it feels warm on touch. So it's just signaling that, you know, my under part, the under tissue is under pressure and is under trauma. Please, can you do something to prevent my breakdown? So we need them to look at that area and then prevent it as possible as you can. And to manage at this stage, it's very cheaper compared to following stages. So we need to relieve the pressure on the affected area. So we need to educate the patient, educate the caregivers that you need to do this assessment. And the nice times and the better times to do the assessment is during the bath or the changing of positions. So then for that reason, we need to emphasize and strengthen our positionings and putting more support materials, and then to prevent further damage by putting or applying Vaseline or moisturizing the skin, and avoiding frictions or pullings, especially during maneuvers to and out of bed or during changing of positions. Teaching our patients how to use the linens to change positions, as we have been taught during our nursing schools. Ensuring proper nutrition and hydration to promote the skin health, so that they encourage them to take fluids. And remember, when you're increasing hydration, we need to put measures to control incontinence. So maybe we need to put catheterization. For men, now we even have condom catheters. So yeah, and issues to protect the bed and stuff. So that's what you need to do. And at this point, if you look here, non-pharmacological measures are used. There's no drug here. It's the cheapest stage, but sometimes we find out our patients will pass this stage related due to different conditions or factors. And then once it goes to stage 2, now it has gone to the partial thickness of the skin, and now you have an open wound, definitely. And at this point in time, it's still early. It looks like a blister wise. So if you have done proper assessment of your patients, well, but you will identify it as early as possible. And at this point, you don't have a lot of work to do, except that you keep your wound clean and moist to promote healing. So we use sterile saline or boiled warm salt water at home. So we encourage them to use that one because it's what's available at home. And then we use the appropriate dressing. Sometimes we need just gauze and a strapping. But then I need to say that we need to be very cautious when we are going to use either wet or dry gauze to dress a wound. Because then we need to understand that when you put a dry gauze on a moist wound, the gauze will eat the moisture and leave the wound dry. And then you end up having a dry wound, which you don't want. Another thing is that when you put your moist or wet gauze on top, we need to be aware that the gauze at some point will be dry and later drain the wound. So what does it mean? Whenever you are going to dress with a gauze, just gauze, we need to assess the wound as quick as possible, not take very long, so that we prevent the wound being dry. It's whether it's wet, we have wetted it normal or what, but you need to change it at least daily and check if it's not leaving your wound dry. And whenever then we are changing the dressing, be careful when you're removing the gauze from the wound, because chances are it will stick on the wound. When you remove the dressing, it will cause trauma on the wound base. Then the wound base will be bleeding. Every time you are changing the dressing, it will be bleeding. Bleeding wounds is a sign of delayed healing. So we don't want that. So whenever we are using the dry gauze, we need to be cautious of that. But then we use bandages and stuff. And then to prevent, as I've mentioned, that we use a proper dressing. I was just sharing on on gauze dressings, that we need to be very cautious because sometimes it's available, but then we need to monitor it very closely, whether we used wet or dry. So we are using those dressings to prevent infection and protect the wound from trauma. So we need to be cautious and do that as early as possible. And we need to continue put measures to prevent pressure ulcers on the other areas, because we don't want pressure ulcers to continue, and also prevent pressure on the affected area, because if then pressure will go to that wound again, you find that then the wound will develop faster, because then now there are more dead cells being produced because there's no proper oxygen or blood supply to that area. So then the wound progress faster. But then you find that the patient is a multiple wound. That's a difficult scenario. That's the reason we need to prevent pressure ulcers as possible as we can. And yeah. And then another issue at this stage in time, it is very appropriate also to address any underlying medical conditions that may contribute to development of the pressure ulcer. What could be the cause of this pressure ulcer? Remember, when we started this module, we said whenever you are addressing any symptom or problem, don't address the superficial part of the problem. Get the root cause and uproot it as possible as you can. But if it is a problem that cannot be reversed, then we need to palliate the symptom. So then that's when we make the decisions and align the goals of care with the patient and prevent suffering and alleviate suffering. So we need to agree with the patient on what to be done. So yeah. And then we have stage 3. And this one, oh my goodness, trouble is in the house, because now it has gone to the underlying tissues. It's a little bit deeper now. And this one, sometimes it requires advanced wound care tactics or procedures. At this point in time, you might find that there are now scars. You now need debridement of dead tissues on the wound base to give the wound base and space for perforation. It's for perfusion, actually, not perforation, for blood perfusion, so that then oxygen can flow. We need to be aggressive on infection control. So yeah, now it's very tough. So if we could intervene as early as possible, here we will need your alignments, you will need your SSDs, depending on you will need your silver, okay, as I've mentioned, silver satazide creams, you need your antibiotic creams as mentioned. But remember, even if you want to deal with this wound, don't apply betadine and leave it in the wound. Let me mention this one. If you leave betadine in the wound, betadine is an antibiotic. What it will do, it will kill the bacteria in the wound base. Definitely it will do that. Unfortunately, if it's there in the wound, it goes further and destroys the live cells again that you need for the wound to heal. So that's why then we need to be very cautious of those antibiotics that kills the live cells too. So we better not use them, because if it does, you will see that your wound will keep on deeping, because the betadine does the work you were intending to do, but then it goes further. Yeah. So then we need to offload manage pressure areas to avoid further damage, as I've mentioned. And then when you go to stage 4, even in stage 4, sometimes you can even see the bone. What is very important here, when you're going as deeper the wound is, the aggressive assessment needs to be. Looking at the undermining, especially in stage 4, sometimes there will be a lot of undermining. The wound will be deeper than you can see. It goes wider, so you need to to check it deeper very well. And also here, you find that sometimes there will be going extent as if into flap reconstruction or skin grafting. So all measures will be tried. Debridement and all those things will be done here. But remember, proper dressing without even going there, maybe sometimes you will use the hydrocolloids, sometimes, but if you will clean your wound very well and keep it clean, prevent the maggots to come in, because that's another enemy at stage 3, 4 that usually comes in, that you find that your patient then gets maggots. So we need to prevent that. And these wounds are very smelly, and we need to prevent control smell at all costs using non-thermal closure. Means you can use the kitty, things that we put by the door, and then you put a perfume charcoal, then you spray it circulates in the house and chase away flies and give your patient at peace. You will use our what we call this, fletching, crushing stuff to chase it. Yeah, betadine does eliminate smell, but damages the wound further. So we better avoid it at this point in time. And then we manage our complications, and we promote mobility wherever possible. Whenever not, we engage on range of motions so that circulation can be encouraged. And remember, there's no drug that can heal a wound. It's when the environment is favorable for the wound to heal. Maybe to conclude on a pressure ulcer management, I can say that whenever we are managing a pressure ulcer, we just not to focus on the pressure ulcer itself only, but we have to focus on the holistic management that addresses the patient's physical, emotional, and psychological needs at a point in time. This may include management of wound care, which is one, and the nutritional support. If we cannot provide the nutritional support, we mobilize. We are told that if you cannot have it, you link, you put your resource mobilization skills, and then you mobilize and help them. And we work as a team with the patient, and I think we'll deal with that one in our next module, which is supportive care, when we will be looking at the interdisciplinary team and how it works. So we do that. We look at psychosocial interventions, which will include psychological care and social support, to improve the quality of life and promote comfort of the patient. And then when we look at psychological issues, we include the kittens, we include smell control actually. We talk of neglect and rejection by people, isolation. We deal all those things. We deal with all the traumas that the patient are going through. And then as healthcare providers in palliative care settings should collaborate with multidisciplinary team. We work together as a team with other people, specialists if they are there. We engage them, they come and help us where we can. We get nutritionists and dietitians as possible as we can, because they know how best to help fight the pressure ulcers dietary-wise. We get physical therapists. That's why we need the team from Cheshire. I know at RFM we have physiotherapists there. We need those guys to help us deal with wounds. We have social workers that deals with the psychosocial part of it. We need psychologists who goes to social workers to deal with the psychosocial. We need traditionalists. We need spiritual people, like we need our chaplains, our traditional people. So we invest on those things. So all these people, they need to come together to support the patient and improve. So we have all these resources as palliative care teams to work with. The issue is, can we mobilize them? Can we identify them and bring them to our teams? As we are today here as a multidisciplinary team with different skills, we can then use those things together. I know this patient needs debridement, I engage RFM hospital. I know this patient needs pain, I engage Moneni. I'm making example. This patient is cancer, needs chemo. So for us to deal with this pressure, so we also need to deal with the cancer behind. This patient needs dialysis, I have Baba. So we need to work together as a team. By implementing evidence-based interventions, very important to have the R&D units in our facilities, whereby then we have evidence. We get to know the evidence and use it. We do research, we do pioneering new evidence, sometimes getting to know how patients are doing these things and promote those things. So we need to use those evidences and help us to improve our care. So through research, we have been able to eliminate hydrogen peroxide. We've been able to eliminate currently the use of betadine in healable wounds. So we are using those evidences to move our patients forward and manage pressure ulcers, because then that one will help us help our patients do better. And through palliative care researches, we are able to know at this point in time, this is what we need to do. Thank you so much. That's what I can present on pressure ulcers, colleagues. May I leave this opportunity for us to share our experiences, if we can. For these moments, can we share our experiences if we can? If there is something you feel like, I also have this experience with managing a pressure ulcer that I think we can also embrace as a team and learn from one another on that aspect. Yes, I can appreciate that. One time I was going to Mbabane and I met a patient who told me that arthritis pain can be relieved by applying castor oil on the knees. It was my first time to learn about it, and I still need to practice and see it. Is it true? Yes, I checked on the web. I see something going there. So can we share? I have 5-6 minutes or 10 for us to share. Anyone who wants to share his experience with us on what best we can, or add to the presentation, or comment on the presentation. What I can say is that most of palliative care patients do develop pressure. As I said, we have seen 10 to 20% of patients with palliative care conditions develop pressure ulcers at home. And fortunately enough, we can prevent it through team approach with the caregivers, with the team specialists and everyone involved. We can prevent it. And believe me, managing pressure sores, very expensive. And through palliative care, we can cut the bill towards wound management. We can reduce the cost of buying, traveling to wound management facilities. We can through palliative care. How? Strengthening education and training, supportive care, team support, one another, we can prevent. Being proactive, we can. Just talking and waiting to see anyone raising his hand. Anyone who wants to say something? Anyone wants to share? Or have any challenge you want to share? Or have you have an experience that was so awesome? How does it feel when you see a wound healing slowly going back? It feels nice. So anyone wants to share? Okay. I don't know whether not yet, or yeah. Yes, Cyprian, welcome, sir.
Good afternoon, team.
After a long time.
I'm sorry for being away for a long time. It's because of work. Every time I've been assigned somewhere outside the hospital in the Pundu sometimes.
Yeah.
So you find that I get challenged to be connected.
Yeah.
So one patient that I remember when I was still working there in the hospital, the patient was quadriplegic. You know, quadriplegia. Sometimes they cannot even move their arms, they cannot move their legs. So eventually, there's patients. I mean, such patients they normally passed away because they need an assistant 24 hours next to them. So it was the wounds were so bad, in the sacral, the gluteal area, all over. But I mean, the mother was taking good care of the client. The client was involved in a car accident, and he broke the lumbar, the spine from the thoracic region. So she couldn't make it. Yeah.
That was tough. Yeah.
Yeah.
That you know, we have seen some of those clients in our care. That's true. And most of the time, you know, I don't know, can we be proactive though? And encourage our teams in the past that, you know what, one of the things we need to engage our caregivers and patients who has conditions like the one MVAs, who have neurological problems due to MVA or other stuff. Maybe we can just open those discussions as early as possible. That one of the things that you will see, but you can prevent, it's pressure ulcers. And educate them how will they be able to prevent them at home and encourage them to start while the skin looks fresh and nice. Because they can prevent it. Unfortunately, because of lack of education or proactive measures in our public level units, you find that they wait until now the pressure sores are here. And then we begin to educate them now because there's a problem. And we suffer. And it's very painful to see them die in pressure sores. It's very painful. But we can prevent that. We can. And with aggressive and team approach, including specialists, including everyone, we can even try to reverse mild to moderate pressure sores. Thank you so much, Cyprian, to share that. It is common. We also have them in palliative care home base who has already developed pressure sores. Now that sometimes we don't have supplies, we find that there's no gauze, there's no one. It's very bad. But can we try prevention measures? Anyone else wants to say something, colleagues? We are just looking at pressure sore management in palliative care. It is possible. We can prevent it, and it is a reversible symptom. We can reverse it in most cases, and we can prevent it in most cases. So, but we need to be more proactive than reactive to a problem that is already there. Through early identification of patients in need of palliative care, proper and aggressive comprehensive assessment of these patients, and then management through team approach, we can deal with pressure ulcers. In our context in Eswatini, we all know where we are standing in terms of procurement and supplies. You know, we all know, I don't need to discuss it in this platform, but we know what we are going through currently with our clients in terms of the availability of supplies. Some of the supplies are not there and they are hard to find. Let alone, patients sometimes, you know, infrastructurally cannot reach hospital, maybe financial, economically, down to the booths where CPA usually goes. They cannot afford to come to Mbabane, RFM, whatever clinic. So we cannot also go to them maybe as we wish. We could be there daily. You know, we are pressed in all ways, economical and otherwise, but we can prevent through empowering the families, identifying them, you know, risk management, identifying the risk, the potential risk, and then discussing with the families. What I've discovered, they appreciate it as much as possible. One day I will share with you another story I've heard with the patient, but I think when we will be doing a module on end of life care and stuff, I will share it then. It was my experience also in palliative care, you know. Yes, in the absence of any question on this topic, may I leave the room for a case presentation for our next session, which will be on the mambo, which will be on the 22nd of May, which is 22 May. We will be doing our last session on this module, symptom control in palliative care. We will be doing it 22 May, 1 p.m. We will be doing malignant wound. In short, non-healing wound. Dealing with the one that will be there until the end. We will be looking at how best we can manage that one in palliative care. How best we can do that one. We'll be doing it 22 May. So please, let's all come. After that session, we will also share with you post-module test, which will then help us send you through ECO your attendance certificate with your hours of attendance for this module, in case you want to register in June, in July when the year starts, so that you can link this session on symptom management and all these hours that 15 or so hours we have been able to attend all of them. But then, nice news please gear yourself for the next coming powerful module, which will be supportive care, where we will be looking at biopsychosocial spiritual assessment and management, looking at interdisciplinary team approach, where we will be looking at how to break bad news well again as a repeat. We'll do it again. And we're looking at facilitating a family meeting, handling conflicts at a family meeting level. You know, dealing with a difficult family meeting. We'll be looking how best we can handle the family meeting. We'll be dealing at doing family needs assessment. How do you go about doing family needs assessment? How do you go about providing support to the family? How do you go about that? Across the disease trajectory from diagnosis until after the end. We will be looking at identifying social, we will be looking at the real business, you know, that doesn't require Panado, that doesn't require anything. We'll be looking how to support caregivers. When we are facing the caregivers in front, how to support them. Supportive care of children. How do we support children of the person who is sick? How do we go about it in palliative care? We'll be dealing with grief and bereavement. As I'm talking, some of us are grieving, you know. How do we deal with it, especially for the patients? We'll deal with the concept of spirituality. We'll look at it. What is it? Why is it important? We will deal with spiritual care. How do I provide it? We'll enjoy this one. And also, we'll talk about sexuality in real business. We'll talk about it. And then talk about community involvement and support. So it will be a fun, fascinating session. Please gear yourself for that one. But for now, let's meet on the 22nd of May to wrap up symptom control on the malignant wound management. I thank you and wish you all the best. In the chat, I've shared a feedback link. We can be happy to hear you giving us a feedback for this session. Thank you, and let's meet on the 22nd, and then God bless you all. Bye-bye, colleagues. See you.